So, good afternoon, and I thank FRESENIUS for the kind invitation. So, I don't have conflict of interest, but following the participation in the previous session in regard to fluid overload, I must state that I am a cardiologist. Nevertheless, I am very interested in critical care nephrology. So, for patients admitted to the ICU, the occurrence of fluid overload is common and is allied with damage to various organ systems. This includes the heart, the kidneys, the lungs, the central nervous system, and the abdominal viscera. Ultimately, this will translate in many patients to increased mortality. This is one of the pioneer studies by Dina Cruz among patients admitted to the general ICUs. And we actually demonstrated similar results among patients admitted to the cardiac ICU. In both cases, we can see that the curves separate early, that is within 24 hours, and that even mild elevation of the fluid overload, that is the presence of more than 2 liters of fluid overload, is associated with increased mortality. Now, for patients admitted to the ICU, continuous monitoring of various hemodynamic parameters is of great importance in order for us to detect dynamic changes in the values of blood pressure, pulse, saturation, etc. And in that aspect, the monitoring of urinary output is of importance, not only for the detection of renal function deterioration, but also for the management of fluid balance. Now, the recently introduced renal sense system is a real-time sensor-based electronic monitoring of urinary output, enabling us to have a graphic demonstration of early changes in urinary flow dynamics and trends. I can now show you a few examples of how we implemented the utilization of real-time monitoring of urine flow trends in the management of patients admitted to the ICU, namely the change in pharmacologic treatment and the fluid balance management. So here you can see, for example, a patient admitted with acute compensated heart failure related to pneumonia and sepsis. The patient demonstrated oliguria for 2 hours following his admission. We performed a 300 cc of fluid challenge test, and we can see a very nice response, a positive response to the fluid test. Accordingly, we maintained a fluid chart of 100 cc per hour, and we can see that urinary output was maintained in a normal state. Another patient is an 84-year-old man with cardiogenic shock. We can see again oliguria. This patient was naive to treatment with furosemide, so we performed a furosemide stress test with a very nice response of over 100 cc per hour, demonstrating probably the presence of a reversible ATN. A different patient following cabbage operation, we can see that initially he demonstrated normal urine output, but then we see some decrease in the urine output. This correlated with the presence of a negative fluid balance. So we elevated the amount of fluid given, and we can see that. And we can see a nice decrease in the urinary output again. And last, another patient with acute decompensated heart failure with a normal baseline creatinine, again present with oliguria, with a nice response to the furosemide challenge test. So this gives us an opportunity to understand that probably we have a nice renal reserve. Now, we know that among patients admitted to the ICU, especially patients with acute compensated heart failure, Up to 50% will demonstrate acute worsening of the renal function, resulting in acute cardiorenal syndrome. And we know that acute cardiorenal syndrome goes hand with venous congestion and fluid overload. When we focus here on patients with acute compensated heart failure, we can see here patient management presented parallel with the real-time urine outflow trends. So we can see in the green line the urine outflow presented hourly with the trends, and we can see that oliguria is shown where the urine outflow falls below the threshold of minimum of 0.5 ml per kilo per hour. And we can see that in the vast majority of the time frame, we manage to stay above the level of oliguria. And once we detected oliguria, we have altered the treatment of the patient. So we elevated the level of furosemide in certain cases, or applied initial or continuous doses of furosemide. And we can see that this goes hand with normalization of serum creatinine here in the blue line for both patients. So here we can also see the follow-up of serum creatinine level of several patients with acute compensated heart failure, where the renal system was utilized. Again, we can see what is called the fluid overload paradox. So, albeit initial elevation of serum creatinine, the possession of furosemide and a negative fluid balance was associated with a relatively rapid increase in renal function, and that actually most of patients had normalized the renal function within 48 to 72 hours following admission. And this allied with the presence of a negative fluid balance that was present throughout the hospitalization course. So I think that the most important take-home message should be that among patients admitted to the ICU, early and goal-directed care should be performed with regard to the management of fluid overload. This should go hand with early and continuous follow-up of urinary output, with early detection of dynamic changes and trend in urinary output. And we should personalize the treatment according to the variations that we see, and adjust levels of both diuretics, amines, fluids, etc. for the management of these patients.
So, thank you very much. It's, of course, very, very interesting. We had the chance to use some of these devices in the past. We had some technical challenge. Can you comment on potential technical challenges for the use of urine output monitoring?
So there are some minor technical issues relating to the problems of air in the system, and the fact that the catheter need to be allied with a body of the patient. But generally, I think that following a very, very short time, the utilization in the ICU, which is mainly performed by the nurses. So the nurses are making the connection, and they alert the doctors when they see the trends, the altered trends in urinary output. I think the main benefit is the fact that we see the changes visually. So we see the monitor in front of our eyes, and we don't have to go and look underneath the patient in order to see the urinometer. So we go and see ahead of us every time we make the round. We see the graphic presentation, and we can see the alert monitoring whenever there is over 2 hours of decrease in urinary output.
Two quick questions. How much time do you think is adequate to evaluate a trend?
So I think that 2 hours.
2 hours.
2 hours. So if we see a 2-hour decrease in urinary output, we try to have some degree of intervention. So to see if we need to elevate the levels of IV amines, to give furosemide, to give more fluid, etc.
And do you suggest to trigger the use of biomarker based on this observation?
Definitely, because I think that in many of these cases, the early trend of oliguria will go hand with early elevation of the urinary biomarkers. So we know that the AKI definition, the urinary definition of AKI, will define the AKI as 6 hours of oliguria. But I think that if we will measure urinary biomarkers within 2 to 3 hours of oliguria, we'll already detect some degree of elevation of these biomarkers.
Thank you. Just to respond to some questions coming from the remote audience, when we asked before who's going to use the biomarker currently in the practice, approximately 20% of the audience responded they are using, but 80% responded they are convinced they should use, but they had technical or administration challenges in utilizing biomarkers. So I think it would be important, as we see here, to combine all the means we have to make a proper, accurate, and early diagnosis of AKI.